Hi everyone, I am Dr. Purva Bavikar, a nephrologist based in Aurangabad, Maharashtra. With the background of being a second generation early career nephrologist, I shall be discussing the nitty-gritties of setting up a kidney transplant unit.
So let's find out how to set up a kidney transplant program in your hospital. At present, there are 546 NOTTO approved kidney transplant units in India. Since I belong to Maharashtra, my inputs would largely be based on this state. And my disclaimer is that the process may vary 10 to 20% as per the state you wish to have a transplant unit at. For the purpose of covering all aspects, I will discuss the technicalities of the setup, the legalities, the infrastructure, the finances, and my personal opinion. One should know about the Organ Transplant Act, the NOTO forms, especially 12, 13, 17, and 18, state specific rules and regulations, and NABH requirements pertaining to the infrastructure of the hospital, the manpower required, and the diagnostics. Majority of the information is available online. So, briefly coming to the application process, it starts by filling up of the form 12, which is available on the NOTO website. This form is wholesome and will cover all the aspects of hospital requirements needed to set up the KT program. Next comes approaching the Directorate of Health Services, state, and the local civil surgeon for inspection and approvals for getting permission for starting the kidney transplant program. Now, those hospitals doing 25 kidney transplants per year eventually become autonomous and can have their own authorizing committee. This information about definitions of authorizing committee, etc., are well described in the Transplantation of Human Organs Act 2014. Coming to the hospital requirements, the bare minimum as Form 12, with the idea of widening the donor pool, in the near future, it may be required that an organ transplant unit shall also be an organ retrieval unit. So, requirements are more or less the same for both. So, let's start with the first part of Form 12, which asks for hospital details. The minimum number of beds is undefined. Again, a disclaimer, a multi-speciality hospital shall preferably be 100 bedded, while a single specialty hospital can be anywhere between 30 to 100 beds. I have arrived at these numbers after studying the NOTO approved hospitals data and the Mahatma Jyotirao Phule Jan Arogya Yojana, which is a health scheme for patients in Maharashtra. The information about these is available on their website. There are a few centers in India catering to nephrourology only, like the one in Nadiad and Asian Institute of Nephrourology in Hyderabad. You should study their models in depth to get a fair understanding of how they have set up their kidney transplant unit. So, the manpower for the program is a team of transplant doctors, trained nursing and OT technicians, transplant coordinator, ICU staff, support staff from administration, billing, legal team, and social workers. Amongst the doctors, we need to have surgeons, physicians, anesthetists, pathologists, microbiologists, radiologists, of course, the nephrologist, urologist, cardiologist, neurologist, and neurosurgeon. I shall briefly describe the role of each in the coming slides. The qualification of each transplant team member will be as per the state you are practicing in. In fact, as per my knowledge, a nephrologist can independently start doing transplants with a minimum experience of 2 years post DM or DNB nephrology. In some states, surgeons with an experience in transplantation are accepted, and the qualification criteria of being an MCH or be having a super specialty remains vague. So, what are the qualities you would want to have in the kidney transplant surgeon who will be taking care of the urological aspect and the vascular aspect? You can have two separate experts, or it can be just one specialist doing both the jobs. So, The quality that we are looking for is a high team spirit threshold. The surgical ATN rate should be zero. Transplant renal artery stenosis rate should be zero. Complications like lymphocele, urinoma, ureteric leak should be rare. For a transplant physician, there should be a quality threshold pertaining to there should be a quality threshold pertaining to procedural skills, awareness and stewardship for immunosuppression, antibiotics, fluids, acid base electrolyte balances, and ability. There should be a quality threshold pertaining to procedural skills, awareness and stewardship for immunosuppression, antibiotics, fluids, acid base electrolyte balances, and ability to identify problem situations with early clinical diagnosis, especially valuable in tricky situations. The anesthetist's ability to induce and bring the patient out of different planes of anesthesia is one quality we are looking at when the anesthesia team is concerned. Their ability to give analgesia to patients with an ejection fraction of 30% or having uncontrolled diabetes, hypertension, their ability of providing epidural anesthesia, CVP catheters, fluid management in fluctuating blood pressures under anesthesia is a quality that will help the transplant program be a success. Last but not the least is quality and ability of the intensive care unit support in case if of a kidney transplant recipient crashing midnight. This is the transplant team organogram at Symbiosis Hospital, Pune. Next, coming to the bare minimum requirements of departments you must have. Although you need to have a basic lab and radiological investigation should be available, but can you have a transplant unit without an HLA lab, without an MRI machine, without the equipment for testing tacrolimus levels or genetic typing? The answer is yes. And DIAPS is the solution. We are doing kidney transplants in tier 2 cities like Aurangabad, Nashik, where resources are limited, but transplant programs were established since 1990s. All necessary documentation with the collaborating center is mandatory, providing the distance between the KT unit and the center, invariably on a 100 rupee stamp paper. You need to have a defined turnaround time, that is the TAT, and choose your partners and vendors wisely. It is advisable to have an independent pharmacy and lab for the center you want to establish a KT unit in to maintain uniformity of reporting and quality of immunosuppression. Next comes the pharmacy supply chain, where the drugs should be made available before doing the transplant. It is mandatory to have a dialysis unit, ICU, in-house modular OT, minimum 2 to 3 for the program. Again, these numbers are variable based on a single specialty versus a multi-specialty hospital. So what is a modular OT? You can refer to NABH guidelines for air conditioning 2018. A modular OT designated for kidney transplant and kidney transplant alone would be wonderful to have, but in real life, to balance the financial burden of the hospital and cater to the management aspect of return on investment and things like that, it's difficult to have an exclusive kidney transplant OT in a single specialty private hospital. Conventional OT is a brick and mortar structure, while modular OT has modular panels, which can be assembled, disassembled, and allow for maintaining a sterile environment. Modular OT has an advanced air filtration setup with laminar flow system, positive pressure environments. The key word here is sterility. So, whatever architecture and infrastructure can provide sterility in the OT, ICU, KT unit rooms will serve the purpose. A central sterile services department, that is CSST unit, is mandatory for having a kidney transplant program. Special requirements and standard operating procedures specific to OT, ICU rooms, surgery can be customized in consultation with these experts. A green corridor is a route in which all the traffic signals that come in the route of the hospital where an organ is being harvested and the hospital where it is going to be transplanted are green and controlled manually. Basic SOP to have a green corridor in Maharashtra is established by ZTCC. Moving on, how much money is needed to have a transplant unit? It all depends on which sector are you looking at. Public sector or government aided institutes have different norms than private sector. I will mainly focus on the pink part, that is the private sector. The ideal and rational of both the sectors is more or less the same. Also, starting a KT program in a multi specialty hospital is a lot easier than a single specialty hospital. Coming back to the hot question of how much money is needed, if you're starting from scratch, you're looking at 15 to 20 crores to begin with, which includes land lease, brick to building cost of construction, equipment, manpower salaries, and the whole hospital business for a period of 3 business years in a tier 2 city. If you're looking at a transplant unit in an already established hospital with NABH accreditation, investment is as per actuals to complete legalities and fulfillment of Form 12. I want to emphasize on NABH. Is NABH accreditation mandatory to have a transplant unit program? No, but it is desired to have it. Since NABH is gradually becoming a reference point for hospital establishments, accredited hospitals have all the requirements and their SOPs make formation of transplant unit methodical and hassle free because of available checklists. The next few slides highlight the role of nephrologist expertise. This includes basic diagnostics needed pre and post KT, the process of admission, peri-transplant discharge, all need to be defined. So, this is the universal process of transplantation in India. Medical legal issues that a nephrologist must remember to provide ethical practice is doing living related kidney transplants as advised by NOTTO by establishing donor recipient relationship and certifying it through Form 5. Coming to the standard operating procedures that need to be set and implemented by a nephrologist or kidney transplant unit in charge. Pre-transplant evaluation of donor and recipients. At our center, we have divided them into 4 visits as some of the investigations are being outsourced. All routine samples, blood grouping and screening is done in visit 1, and visit 2 is radiology and cardiology fitnesses and donor DTPA renogram. In the third visit, we ask for donor CT renal angiogram and NCCT pelvis of recipient for iliac vessel calcification in case of diabetics. The fourth visit, which is prior to police verification, involves HLA cross matching in case of ABO incompatible kidney transplant. Anti-blood type antibody titers are done in first 2 visits. All this can be done in 1 or 2 visits as well, but splitting the investigations reduces the financial burden of the patient. It is less scary, establishes doctor-patient relationship, and is helpful to rule out foul play owing to its periodicity. So once living donor recipient pair has got permission from authorizing committee, the pair is hospitalized. This is an SOP of a hospital in Aurangabad. Patient and donor are admitted 1 to 2 days prior to surgery. Immunosuppression is started. Patient undergoes surgery. Recipient is admitted in KT ICU for 10 days, while donor is admitted in the medical ICU for 3 days and then shifted to a private room for 2 to 4 days. Recipient is discharged on day 10 directly from the ICU, while the donor is discharged on day 5 to 7. Timely video counseling, recipient education, memorizing of immunosuppression, home care is also taught during hospitalization. Sutures are removed as per urologist after discharge. Patient follows up on Mondays and Thursdays with investigations for first month. So what happens in diseased organ transplant? Let's say a 20-year-old is admitted as a case of road traffic accident at your hospital, which happens to be a retrieval center too. he's in a critical state and eventually becomes brain dead. Brain death is certified by a neurologist, neurosurgeon, any surgeon, physician, anesthetist, or intensivist nominated by medical administrator in charge of that hospital. The process that goes in for organ harvesting and retrieval is high priority and laborious. Multiple things have to be taken care of and done within a short span of time. The treating ICU team takes care of brain dead patient, the patient's labs, investigations, hemodynamic stabilization. Transplant coordinator counsels the family and informs ZTCC. Once consent is given for organ donation, kidney transplant waiting list CKD patients are called based on blood group and NOTTO allocation criteria score. Ideally, 3 candidates should reach the hospital. Why 3? Because in case crotch match is positive for the number 1 patient, you have 2 other prospects. So once the deceased donor is posted for organ harvesting, the prospective recipient must undergo these processes. Time is key in disease donor kidney transplantation. If the organ harvest and the kidney transplant happens to be in the in-house, that is in the same hospital, the technical procedure is similar to living donation. That is, once organ is harvested, it can be immediately anastomosed to recipient with a short cold ischemia time. If the organ is received through green corridor, it is always useful to have prospective recipient ready before the organ reaches your hospital. This is the timeline and the processes that have to occur all at once. Cross matching diseased donor with the prospective recipient is what a nephrologist looks at first, followed by stabilization of the prospective recipient. So you need to keep in mind that you may have to dialyze the patient before transplantation, because if the dialysis has been done 24 to 48 hours before, then patient may be acidotic, uremic, having fluid overload. And in that situation, a few extra hours are spent dialyzing the patient before he or she receives the graft. Minimum duration we have worked in is 6 hours when I was working in Pune. Now, coming to personal opinion, after discussing with multiple nephrologists at various stages of practice, the advice that remains pertinent is choose whether you want to be a healthcare industry service provider or a nephrologist running a transplant unit. Is both possible? Yes. At the expense of having a chaotic work life, family, personal space, your fitness. This job is demanding. It is also possible if you're extremely well equipped with resources and finances. Nonetheless, I don't mean to discourage anyone, but it is a challenging job to be both. Now, choosing to be a nephrologist running a transplant unit is more or less like 1 plus 1 equal to 2, 1 plus 1 equal to 4. As far as setting up is concerned, as of 2023, NOTTO is a dynamic body and has simplified a lot of things to encourage transplant. So all you need to do is just follow the guidelines, fulfill the requirements of Form 12 and the state specific rules and regulations, and you can start the kidney transplant program. Starting the kidney transplant program is not a big of a hassle as much as maintaining the program is. You can get the permissions if everything is in place. Now, if you want to be a service provider who owns a hospital and wants to start a kidney transplant program, I would say have an extremely experienced, well trained transplant team. Keep the nephrologist, the urologist, anesthetist, nurses, transplant coordinator, support staff happy. Each has been trained to do their job perfectly. It is advisable you orchestrate and keep communication with each and every person on high priority. There have been mishaps. There have been instances when doctors are the torchbearers to face trouble, be it patient relative bashing, medico legal mishaps. In all these situations, it is the team's skill to tackle this kind of a situation. One more take home message would be the importance of documentation. As of 2023, documentation is key, be it electronic medical records or handwritten records. Documentation, and documentation for doing such a major surgery is vital. Your documentation needs to be taken care of in the matters of OT notes, patient vitals, pre-operative, post-operative, immunosuppression given, lab investigations that are being monitored, counseling of the patients, be it video counseling or written consents, they all need to be documented. So, coming to the maintenance of a successful kidney transplant unit, maintaining what you've started is very important. Have monthly audits with each team to avoid complications, frauds, mishaps, and any breach in the system. Rectify loopholes. Transplant outcomes is crucial. Have checklists, protocols, administrative and legal documentation, patient outcomes, maintain record. Then also have a special team for grievance addressal, which is supposed to be done periodically. Remember, you have to seek renewal after every 5 years from NOTTO. So whatever you've done in those 5 years has to be documented and presented to NOTTO for renewal. Although I haven't discussed swap transplantation, problems faced during setting up, regional issues, management problems, administrative issues, it takes a village for a successful kidney transplant program, and it is a continual lifelong process. So please feel free to contact me. The least I can do for answers I lack knowledge about is probably connect you with someone who can answer your questions. And I wish kidney transplant enthusiasts who want to set up a transplant program in their city, in their hospital, all the best. Thank you.